Hepinize günaydın.
Good morning, everyone. Welcome. This is the second session of the morning, I believe. I would like to thank the organizing committee for making this panel possible and for inviting us at the same time. First of all, I'll provide you with a general framework and then tell you what we are doing in the field of cognition, and I'll talk about neuroscience findings. In general, the normal mental state and the problems of an individual are dealt with four main approaches. One is the biological approaches, the second is behaviorism, and the other ones are the classical ones. And I had an historical approach to this. Biological approach says that normal state or the disease states are related to the brain as the organ for thought memory, and if there is a problem, this is either related to the structure or the function of the brain being disturbed, and we have to see what the problem is and to identify that problem. Roughly, if we are to represent the human being to a computer, the biological approach says that if there is a problem in the functioning of this computer, the problem is usually because of the hardware. There might be a problem with the supply, or Emil Kraepelin was the one who came up with this idea in the field of psychiatry, and in its appearance there are very valid justifications. In these days there is only a single mental state which is equivalent to what we call psychosis today, and in those days psychiatry wards are filled with at least up to 50% with patients who are contracted with neurosyphilis, which is the syphilis organism being present in the brain. Imagine that there are individuals who are confronted with a disease that they do not know of, and imagine that this is caused by a microbe. Of course, vitamin deficiencies were resulting in psychiatric states, and together with the appearance of the biological paradigm, we understand that we can explain these situations with the brain, and this gives us a lot of strength at that time. When this appeared, it was consistent in itself because the diseases it explained were due to the structural abnormalities in the brain, and those diseases that they saw as psychiatric states were schizophrenia, maybe severe manic depressive episodes, and depressions. In fact, the main problem is not in the biological psychiatry of Kraepelin. However, in the new psychiatry, new Kraepelinism, as they call it, was problematic. And at the time of Kraepelin, there were three main psychiatric diseases defined: schizophrenia, manic depressive psychosis, and dementia-like states. And as these were related to biological underlying conditions, it was consistent in itself. Despite the fact that DSM does not make any reference to biology, however, there is an underlying message that all the psychiatric states are related to biology to a certain degree, and as a result of this, schizophrenia is a disease of same category, and also another problem that follows a divorce is handled in the same category. That is why, if Kraepelin had been alive today and had seen DSM, he would see that many of the states would not qualify as psychiatric states as he defined them. And the problem of the DSM, I think, is a diagnostic problem for psychiatry, and as a field of work in psychiatry, we have several problems that confront us. When we are to have a look at its development and historical evolution, together with the increase of the psychiatric conditions, DSM was updated, and in DSM-5 actually this was understood, and they in fact made an economical attempt, and we see that there are 297 categories in DSM-4 while we have 265 in DSM-5. With a small reduction, they have lesser numbers, but the pages of the book are increased. So where does the problem lie? The problem is that if you claim that you make a classification not based on etiology, but you foresee biological factors in the etiology, a problem arises. So for us as psychiatrists, in order to understand the process, for example, major depressive episode, 9 criteria were defined. If 5 are present, if these are present for more than 2 weeks, then we call the process depression. When I was in my fellowship training, and I thought that these were identified with field studies, like depressive patients were researched in the field and then criteria were assigned to them. However, I then learned that psychiatrist was asked about why 5 criteria. Spitzer says that 4 would be too limited, 6 would be too much. So as a committee, they sit down, I realized, and they make a discussion not based on any empirical data. Whoever talks the loudest, rather, has an influence on the decision making. And related to personality disorders and generalized anxiety disorders, radical changes were being mentioned. However, in the end, we are seeing something similar to DSM-4 in DSM-5. Here, while working on this issue in the year 2010, I wondered what would have happened if this was the situation in internal medicine, hyperhydration, hyperphagia, and at least one of the 2 parameters should be there, and these should be present for more than 15 days, and there should be at least 5 of the below parameters. Dry mouth, feeling of having frequent urination, feeling bad when you are fasting, headache, nervousness, and need for sweet foods from time to time, getting hungry very easily and being intolerant to fasting. And these are criteria for diabetes. And if an internal medicine specialist was to diagnose diabetes based on these criteria, how healthy would that be? That is the problem in psychiatry. If you are diagnosed with this condition, you would like to have a blood sugar measured, and you wouldn't take other criteria that seriously. However, then we come to the field of psychiatry. There are certain synthetic categories based on certain criteria, and the clinicians are expected to come up with hypotheses based on these criteria. All of these are hypotheses because you do not have any measure to measure its validity, and all psychiatric diagnoses are doomed to stay as pre-diagnoses, and that is why these situations are rather called disorders, not diseases. And in medicine, these are more in the realm of syndromes than diseases. So we think of brain with a different approach. It is fed through the blood supply, and the medications can end in the brain with the blood supply. Other than other organs, the brain is in charge of evaluating the outer world and creates outputs for the outer world. And it is rather different than the heart or the kidney in that regard. And mental health, what does this entail? Certain things happen around us. For example, you are listening to this presentation, you have perceptions, evaluations regarding this speech, for example, and you have emotional reactions to this, and accompanying this you have certain physiological bodily reactions, and you have this listening behavior. All of these are related. Cognitive behavioral therapy claims that all of these components somehow contribute, and the initiator can be one of these, regardless of what factor initiated the problem. Once the problem starts, all these 5 elements are interacting with each other and resulting in the maintenance or sustainability of the problem itself. So as this is brain related and a cognitive process, we see that there is a relationship between cognition and feelings and reactions and the environment. So we then have certain parameters that we can manipulate, or rather the individual can manipulate. These are the areas of cognition and behavior. If you are to take your kidney in front of you or heart in front of you, you cannot come up with a change by talking. However, the human brain is constantly in front of us and we are interacting with it. So psychotherapy or psychosocial therapies, as they are named, are also biological treatment options. Cognitive biological model by Jesse Wright and colleagues, it was developed. So environmental events are going through a cognitive evaluation. There is a biological modulation through neuronal, neuroendocrine and autonomic mechanisms. This is in close relationship and interaction with emotion. There are psychological elements to it, and these certainly have behavioral tendencies that are shaped by early life, and we have behavioral reactions that are more instinctive, which in the end impact our environment. Cognitive behavioral hypothesis says that there are 2 emotion generative and regulatory processes which are related with cognition. One of these is more automatic, reflexive, from bottom up, and in which primary emotions are developed, like classical
İkincisi de çaba gerektiren
conditioning. The second is more symbolic and it's more top-down and effortful. There are environmental triggers, the genetic and personality traits of the individual. Genetic is from the beginning of the life, and personality develops as a result of genetics interacting with the environment. With certain life events, there might be a negative scheme activation in the individual, and in the biological sense, the brain equivalent is the hyperactivity of the amygdala and hippocampus, which was shown in anxiety, and there is the ventromedial prefrontal cortex. There are functional changes in that area, and this is more an associative process, and the effect regarding this process was shown in different studies with different data. However, this can be interpreted in association with each other. In the presence of a problem, this upper cognitive control disappears, and the lower cortexes, like the lower centers like amygdala, become more active. There are ineffective coping and avoidance, which results in anxious and depressive symptoms. We activate this cognitive control in therapy, and we try to heal the patient by doing this. In fact, here, this is similar to what I said before. In depression, both in treatment and in an effort to explain the depression, there are 4 main studies that have been conducted. The first one is of special importance and a detailed study. In this study, cognitive behavioral therapy was used on certain patients. 17 patients were treated with this treatment, and another group was treated with paroxetine, with a medication. And these patients, PET findings at the beginning and the PET findings at the end of the study were compared in order to identify the difference in between. So we try to see what the medication affects and where the therapy comes into play and what does the therapy affect. The ones that are blue or pale blue shows us that the activity is decreased in that very region, and the red color shows us that the activity is increased. In the slides here, the difference has been imaged. For patients receiving cognitive therapy, what we see is that, especially in the frontal and parietal areas, the activity is decreased. Of course, this was obtained during rest without having the patient do any task. The second is the hippocampus and dorsal midcingulate, and they show an increase in activity. There are decreases in the activity of the hippocampus. This is the universal response to stress. So the increase in the activity in hippocampus is a positive change, we might say, then. And the common change in both therapies is the activity decrease in the ventral and prefrontal cortexes. And the change that was related to the medication was in the subcortical structures like cerebellum, hippocampus and thalamus in the form of activity decrease. The interpretation is as follows. In depressive patients, prefrontal cortex related changes change in a positive manner and decrease. Here, more specifically, if we see the cognitive behavioral therapy related effects, the common effect or joint effect of the medication and the therapy, or the medication effect by itself. In conclusion, it's said that in depression, cognitive behavioral therapy positively affects the frontal cortex activities like hopelessness and seeing yourself inferior to others, and the medications are usually influential on the sleep and appetite. And this also explains the paradoxical suicide by the depressed patients. When the patient feels himself better, he attempts things he could not do in the past because of feeling tired and not wanting it that much. And here you see the suppression of the prefrontal cortex activity, the increase in the amygdala cortex. Both cognitive therapy and medication can increase the prefrontal activity, and the antidepressant treatments are doing the reverse. They are suppressing the activity in the amygdala. amygdala is the center that is orchestrating our fear responses. Fear responses are also present in the animals. That's why this is an effect that is studied in a very widespread manner. So this is a fear stimulant which has been encoded before, and here you see the pathway, the fast pathway going to the amygdala, resulting in the psychological effect. And the physiological stimulation starts even before we appreciate what we have seen. Then we understand what we have seen, and then there is a second pathway which is longer that goes to the amygdala. The difference between the short and the long one is not something we can differentiate. It can be expressed in milliseconds. However, in front of a fear stimulant, we have to be fast in order to be able to survive. So the thing I would like to focus on is that in panic disorder, medications especially desensitize the fear network at the level of amygdala and its projections to hypothalamus and brainstem, and psychological effective treatments like cognitive behavioral treatment affect the prefrontal cortex and hippocampus, and by decreasing the conditioning. So these are the studies. So there is the social phobia, social anxiety study. There are very nice findings about this. Before treatment and after treatment, we show the decreases in brain activity. The areas where there is a decrease, these are subcortical, including the amygdala. These are not related to the cortex of the brain, rather related to the subcortex. Here, with cognitive behavioral therapy, the patients who see a benefit have a difference at the beginning and at the end, and subcortical regions, amygdala, have decreased activity. And there are the patients who have medication. Those who respond to treatment and who don't respond differ, and the difference between the waiting list and behavioral therapy, waiting list and the medication, and the difference between the responders and non-responders. And in a systematic manner, there is a subcortical change, activity change, including the amygdala. Obsessive-compulsive disorder was one of the disease states that was studied earlier in the course of things, and we see that there is an increase in the caudate nucleus. Lewis Baxter from California University conducted a study in 1992. There were patients who improved with fluoxetine, and there were those who improved with cognitive behavioral therapy. At the end of the treatment, orbitofrontal cortex and caudate nucleus activities were decreased, and both drug therapy and biological treatments could result in positive effects in the brain if the patient responds. Maybe what we can say is as follows. The superiority of cognitive behavioral therapy is that it gives more persistent results, and in panic disorder, obsessive-compulsive disorder, or depression, the effects shown by the medication are seen as long as the medication is used, and they disappear once the medication is stopped. So let me finish here. Thank you very much for your attention.